Tēnā koutou katoa. Welcome to this week's webinar. Tonight we are fortunate to have James Blake, who works as a general and interventional cardiologist at Christchurch Hospital with us. James graduated almost 25 years ago from the University of Otago, then trained in cardiology at Green Lane and Christchurch Hospitals, before completing a 2-year coronary, structural heart and peripheral vascular interventional fellowship at William Beaumont Hospital in Michigan, USA. He has a special interest and expertise in coronary and structural heart interventions, including transcatheter aortic valve implantation, TAVIs. Tonight's webinar is titled Contemporary Management of Aortic Stenosis. And I will now hand you over to James. Thank you.
All right, thanks very much. Thanks very much, Kathy, and thank you all for joining us. So as you said, I'm going to talk about the management of aortic stenosis. Just as a bit of an outline of the talk, we're going to talk about incidence of aortic stenosis, the symptoms of AS, the prognostic importance, how to diagnose aortic stenosis, what are the referral options, and the management options, and mainly spend a bit of time at the end talking about TAVI, which stands for transcatheter aortic valve implantation. So firstly, I just want to emphasize how prevalent aortic stenosis is, and it's increasing with time. So prevalent increases with age, with 1 in 8 people over 75 years affected by aortic stenosis. And with our aging population, people, and if you're born today as a female, you've got a 50% chance of living to 100, we're seeing more and more aortic stenosis. So what is aortic stenosis? Aortic stenosis is the narrowing of the valve. It's the outlet valve of the heart. So it's a trileaflet valve, as you can see here. This is a valve open. This is a valve close. And every time the heart pumps, the valve opens, lets the blood come out of the heart. And then the valve closes when the heart relaxes to fill again, basically to stop the blood coming back into the heart. And then the heart pumps and opens and closes. So when your pulse is 70 beats per minute, it opens and closes 70 times per minute. And this is just showing what happens in aortic stenosis when you get calcification and the valve doesn't open fully, and it also often doesn't close fully. So then with aortic stenosis, the blood is unable to flow freely from the left ventricle, which is the major pumping chamber of the heart shown here. They were unable to flow freely from the left ventricle into the aorta, as it should do normally. So aortic stenosis develops very slowly. It's develops over many years, and often people don't have symptoms until it's severe. So that just shows a normal valve, and then this is mild aortic stenosis. And what you get is calcification and lipid deposits on the valve and sort of inflammatory infiltrates. And over time, it develops from being mild to moderate to severe. And everybody's different in how that progresses over a number of years. And when it becomes severe, the leaflets become very stiff, and they basically provide sort of an impediment to blood coming out of the main pumping chamber of the left ventricle. So there are a number of factors that increase the risk of developing aortic stenosis. Obviously, it's a disease of the elderly, advancing age. Other sort of cardiovascular risk factors such as hypertension, diabetes, smoking all increase your risk of aortic stenosis, and other comorbidities such as chronic kidney disease or coronary artery disease also increase the risk of developing AS. So what are the common sort of symptoms? Usually the symptoms are pretty subtle initially when people start to go from moderate to severe AS. So just emphasizing once again that people with mild and moderate AS don't have any symptoms normally. But they start getting symptoms when it's severe. And often fatigue is the first symptoms, or decreased physical activity, decreased exercise capacity. And then people sort of volunteer that they may be short of breath or have palpitations. And usually chest pain and sort of syncope or feeling faint is the sort of the last and more sinister symptoms. And we know that the symptoms of aortic stenosis are often misunderstood by patients, and they just put it down to getting older and sort of the normal signs of aging. Whereas many patients initially, and we know that many patients, they initially deny any symptoms, but if you sort of question them further, many patients actually do have symptoms. So we know that there's a long latent period, as I said, So aortic stenosis develops over a number of years, often in 50-year-olds. You can see the aortic valve starting to calcify. And it's not until average age of sort of late 70s, 80s that the symptoms start to develop. People can get symptoms earlier. And once symptoms develop, the prognosis is poor, especially if you have angina or syncope or heart failure. If you develop a heart failure secondary to aortic stenosis, your prognosis is approximately 2 years. So we know that approximately 50% of untreated patients with severe aortic stenosis will die within 2 years of experiencing symptoms. So, as we've said, aortic stenosis is an insidious disease. It's very much a life-threatening valvular heart disease. It most commonly occurs in the elderly owing to age-related aortic valve calcification. And the characteristics of aortic stenosis, as I said, long latency with no symptoms. Then once you develop symptoms, it's a fairly rapid progression and is associated with a high mortality and a poor prognosis. So this is fairly sobering data. This is comparing the prognosis of severe aortic stenosis versus a number of cancers. This is a 5-year survival. And you see in this 5-year survival of severe aortic stenosis is only about 3%. And that's actually worse than most cancers. So often people think the cancer diagnosis is worse, but it's very important that we diagnose aortic stenosis. So once we diagnose, timely intervention is critical for patients with symptoms, because in the absence of serious comorbid conditions, aortic valve replacement is indicated in the majority of patients with symptomatic aortic stenosis. Because there's a risk of sudden death, replacing the aortic valve should be performed promptly after the onset of symptoms. And we now know that age is not a contraindication to aortic valve replacement. So having said all that, do people get aortic valve replacements? This is relatively old data now, between sort of 1999 and 2000. This is just whether patients underwent cardiac surgery, so open heart surgery aortic valve replacement. And this shows that these are series, excuse me, of patients with severe aortic stenosis. And you can see anywhere from 43% to up to 74% of patients didn't undergo treatment, didn't undergo valve replacement for whatever reason. Often they're relatively elderly and they didn't want to have open heart surgery. So this data and many other data just proves that a number of people, at least 40% of patients with severe aortic stenosis, don't get to have an aortic valve replacement. So diagnosis is very important. And basically, how do we diagnose aortic stenosis? So as we've said, the symptoms of aortic stenosis often not present until the disease becomes severe. So auscultation, getting out your stethoscope and listening to the chest, listening to the heart sounds is the most important first step. And often an aortic stenosis murmur is fairly obvious, it's fairly harsh. Ejection systolic murmur best heard at the left second intercostal space. And if people hear a loud systolic murmur, it's more often than not aortic stenosis. The only other thing it really could be with mitral regurgitation, which is heard best in the apex and often round into the axilla. So any loud systolic murmur is likely to represent significant valve disease. And the aortic stenosis often can be heard over the carotid arteries, so it sort of radiates into the carotids. And it is worth noting that even a faint murmur can indicate significant heart disease, because if the LV function is not normal, then the LV may not be generating a significant gradient that creates the murmur, because the murmur is created by the gradient difference between the left ventricle and the aorta when the turbulent blood flow has to go through a diseased valve. So this is a quote from these important people in 2013, just saying that clinical examination, particularly auscultation, is the first step towards a diagnosis. So we see in hospital a number of people who present with heart failure secondary to aortic stenosis, and they've never had their chest listened to, so no one ever knew they had aortic stenosis. And it's important to bear in mind that even a faint heart murmur may be associated with relevant disease, especially when there is heart failure. So an echocardiogram is really the diagnostic tool of choice. It's the gold standard. We get very good pictures of the aortic valve, even just usually with a transthoracic echo. and will tell us a lot about the valve anatomy, the valve function, whether it's got 2 leaflets or 3 leaflets, and how calcified it is, and also the presence of left ventricular, how good the left ventricular function is, and presence of other valve disease. We also look at the condition of the aorta, and then we do Doppler, which will tell us, it's a Doppler flow will just tell us how severe the flow, how the gradients are across the valve, and that gives us the how we categorize the mild, the moderate, the severe critical aortic stenosis. So timely referral is the key to early diagnosis and prompt treatment. So anyone with symptoms, or pretty much anyone coming into the surgeries, should have their chest listened to occasionally, because we know that they're symptomatic, even with mild to moderate aortic stenosis, and we know that all aortic stenosis progresses with time. So once you've heard a murmur and there's a suspicion of aortic stenosis, then the patient should be referred for an echo or referred to a cardiologist. And we know that, you know, we're not always going to get the murmur right. Even cardiologists can sometimes have difficulty finding, you know, detecting between or differentiating between what is a aortic murmur or a mitral murmur. The most important thing is it gets further evaluated. And so getting an echo, often that's the biggest barrier. We know in Christchurch, anyway, where I work, the echo service is under significant strain, and I suspect that is the case throughout the country. So you know, however we can access it, whether it's through the public hospital or privately, getting an echo is by far the best or the most accurate test for diagnosing aortic stenosis. So what is the referral pathway? So if patient experiences symptoms, so if the GP hears or the nurse practitioner hears a murmur, then obviously getting an echo would be the ideal thing. But if they haven't got any symptoms, then it's probably not urgent. If the patient's got symptoms, or another thing you can do is to have a blood test to check a cardiac BNP. And a BNP stands for brain natriuretic peptide, and that's released from the left ventricle when the heart's under strain. And if the aortic stenosis is significant, a blood test to check BNP will often be elevated, and that'll be an indication that the aortic stenosis is significant and warrants further diagnostic tests and intervention if necessary. So these patients should all eventually see a cardiologist, and if once the aortic stenosis is severe by echo criteria and the patient's got symptoms, even if it's not severe by echo, if it is severe by echo criteria, occasionally the patient still doesn't have symptoms and they should be closely monitored. But then the cardiologist will refer these patients to the heart team. And the heart team is a relatively new concept that's been developed since the transcatheter aortic valve implantation was as an option now. And so there's different options for patients with severe aortic stenosis. So the heart team is a multidisciplinary group of different specialists, including a cardiac surgeon, often a vascular surgeon. There's TAVI coordinators, there's cardiac anaesthetists, there's the interventional cardiologist and the referral cardiologist, and also imaging specialists and the nursing experts. And they all come together and they decide what is the best treatment. We in Christchurch, we have a heart team meeting every 2 weeks, and we decide what is the most appropriate treatment for the patient in front of us. So we've pretty much said that though. So the heart team decides optimal treatment for each patient according to the guidelines once the sort of diagnosis of severe symptomatic aortic stenosis is confirmed. So what are the treatment options for aortic stenosis? So medical management, we know that it can help with symptoms, you know, diuretics can help with symptoms, but generally speaking, there's no medicine that changes the course of the disease. Aortic stenosis is a slowly progressive calcification, degeneration of the valve, and the medication does not change the course of disease. So the options for once a patient develops symptoms and they have severe aortic stenosis is either open heart surgery, where they get a skill saw out, open up the chest, and then take the valve out and put a new one in, or transcatheter valve replacement that's done while the patient's awake, and basically puts a new valve inside the old one. So we'll go into that a little bit more. So surgical aortic valve replacement has been the gold standard of treatment up until probably 10 years ago. But even for relatively low risk patients, we know it carries significant morbidity as well as mortality. So, you know, patients all are obviously done under general anesthetic. They all go on a ventilator. They're all still on the ventilator the next day. And, you know, they'll probably be in the hospital for a week. And we know there's a significant mortality associated with surgical aortic valve replacement. And if you associate it with putting on coronary artery bypass grafts, which is often the case because people often have, you know, coronary disease at the same time, that risk increases slightly. Often now, though, the patients are presenting later and they often have other high risk sort of comorbidities. And so patients, if they're greater than 80 years, if their heart function is depressed, if they've had previous open heart surgery, so they've had a previous stenotomy for bypass surgery, if they've got chronic kidney disease or peripheral vascular disease or chronic lung disease, then often we're dealing with patients with severe symptomatic aortic stenosis who have a mortality of, you know, 20 to 30% if they were going to undergo an operation. And so that's not great odds. So TAVI was initially developed for these very high risk patients. And I'll just now show a animation of what a transcatheter aortic valve replacement. We'll just go through an animation of it. So we come in via the femoral artery, so we get access through the femoral artery, and as I said, the patients will wait. And what's this showing now is just a balloon coming up the aorta. There's a wire sitting in the left ventricle. This is the stenosed aortic valve here, and this is just what's called a balloon aortic valvuloplasty. And what that does is just create space for the new valve to go in, to be able to get the new valve across. So now that's just going back down the aorta. This is what we call a sheath that's sitting in from the femoral artery into the aorta. This is the valve coming in now, and this is the delivery apparatus. So basically, the valve's crimped down, and now the balloon's been pulled back into the valve, and then it's accurately placed on the balloon. This is what we call the nose cone to help negotiate the catheter around the aorta. So this is coming around the arch, and what we want to do is sort of keep it off the wall of the aortic arch. So this is coming around the aorta now. This is quite a stiff wire that's sitting in the left ventricle going through the valve. We do that at the start. So now we're just advancing through the valve, and we're going to position the valve very carefully in so basically sure it makes the right positioning. There's little markers on the valve to do that. And then once we're happy, we pace the heart at a very, so we're just positioning it here. And so we pace the heart at I'll stop it there. Oh, that was the wrong thing to do. Oh, sorry. So now we're just going back. So when we deploy the valve, we pace the heart to basically stop the stroke volume, stop the blood coming out of the heart just for about 10 seconds. So the valve's not misplaced as we deploy it. And you'll see now the heart will start sort of fibrillating here. So the stops, and then this balloon is deployed and the valve starts working. Now the balloon's down and the valve starts working straight away. The balloon's taken out, the wire's still there, and we measure the pressure gradients and things to make sure we have a look on the echo to make sure the valve's working perfectly. So this is the sheath. So now the sheath will be taken out over the wire, and then we close the hole in the femoral artery with a couple of stitches. And this is all done while the patient's awake. And the valve is working perfectly straight away. So the new valve is sitting, we use the calcification of the old valve, and it's sort of splayed back to keep the new valve in place. And that new valve starts working straight away. So this is just a summary of the what I just showed really. So this is the valve coming up. So the valve's been compressed, and it comes up around the arch, and we position it across the old valve, the very stenosed calcified valve. It's precisely positioned, and then we blow up the balloon with a sort of inflation device that we have, outside the body. We blow up the balloon. The valve is expanded within the native valve, and the native valve gets sort of splayed back. And then we take the balloon and the catheter out, and the valve's working straight away. So this is the third generation of valve that we are now using. It's called the SAPIEN 3 transcatheter heart valve. And the technology, it's been around for about sort of 10 to 12 years, and the technology's improved greatly. And these leaflets are made from bovine pericardium, and they're actually the same leaflets are made that the surgical tissue valves are made of. So the surgeon puts in the same sort of valve. There's a skirt around the outside of the valve, and that one of the problems with the first generation and second generation valves is that they there was a bit of a leak outside the valve, so what we call perivalvular, so outside the valve regurgitation, so a leak from the aorta going back in the ventricle, because this is obviously a circular structure, and the annulus of the aortic valve is not a perfect circle, and there's little bits of calcium and things like that, so there's little crevices for blood to leak back through. And this skirt expands into those and almost excludes any leak around the valve. This is really just showing the delivery system and the technology of this. We don't need to go through this, but the technology has improved significantly on the delivery system. It's got smaller, it's got the placement of the valves got way more precise. So this is just so that, again, the procedure is done under local anesthetic. At the moment, we do have an anaesthetist present, a cardiac anaesthetist, just give a little bit of conscious sedation, but that's not essential. And we started with a 22 French sheath, so that's a big hole in the artery. We're now down to 14 French, which we close with a couple of sutures. And when we deploy the valve, we used to put in a temporary pacing wire via the vein, but now we just use the wire that's already sitting in the left ventricle, and we just put a pacemaker connected to that, and we pace the heart at 180 beats per minute, which stops the cardiac output. So I thought I'd just show a typical case as well. So a patient that we did not so long ago, 81-year-old female. She's been known to have aortic stenosis for 5 or 6 years, been followed in the clinic with sort of initially 2 yearly, then more recently, once it gets more severe, 1 yearly echoes. And as soon as she's developed symptoms, we work her up for a TAVI. So she's got normal heart function. She's got near normal coronary arteries. It's important to know what the coronary arteries are like. Occasionally we stent coronary arteries before we put a TAVI in. She's got, high blood pressure on treatment, and she's also got carotid artery disease that hasn't caused any symptoms. So she's a highly functioning 81-year-old living independently, still driving a car. But, a TAVI was a good thing for her rather than open heart surgery. So before we do a TAVI, we do a CT scan. We call it CT TAVI, and that tells us a lot of information about the heart valve. And we size the aorta off the CT scan. We now have 4 sizes of the TAVI valves to put in. So here we're showing this is the annulus of the aortic valve, and we're sizing and we trace around that to get the size of the TAVI valve to put in. And there's 3 leaflets of the aortic valve. And you can see the white is a calcification on the leaflet tips. This shows the calcification, the heavy calcification. And we put the new valve in through this. And then we're just measuring the height of the coronaries away from the valve. So we need to make sure the coronary heights are about 10 millimeters or greater, so we don't obstruct the coronaries when we put the new valve in. And the CT is also very important for analyzing the peripheral vasculature, because this shows the femoral and iliac arteries going onto the aorta on the right and left, because this is the artery that we go through. We make a reasonable size hole in this artery. So this is the skin, this is the surface here. So we need to go down with a needle from the skin surface down into the artery. And this is the best place. So we work out from the CT what is the best place to puncture the femoral artery, and we do that under ultrasound. We go through, and so on this patient, the right femoral is actually very good. There's no calcification, but here on the left femoral, you can actually see there's quite a lot of white speckling there, which is the calcification. And this also just shows her coronary angiogram. The patients all have a coronary angiogram first, just to make sure their coronary arteries are normal. And this is for people who haven't seen a coronary angiogram before. This is obviously the heart's moving, and this is the catheter here, and we're injecting dye down the arteries. And this patient's coronary arteries at the age of 81 are pretty much normal, which is very good for her. And this is just a still picture showing the coronary arteries again. So the catheter was here. This was the left main. This is the LAD coming down here. And we can see pretty easily if there's any severe narrowings there. And these are branches of it. This is the circumflex artery coming over the top. And this is a different catheter now in the right coronary artery. And you can see that all looks very normal. So this is just the picture of her valve going in. So what we've got is the wire sitting in the left ventricle. This is what we call a pigtail catheter sitting above the valve. We'll let it play through again. And what we do, we inject dye, just make sure it's in the right position. That's a good position. And now we're blowing up the balloon. And the balloon's blown up. The balloon comes down. We suck the fluid to get out of the balloon again. We take the balloon out. And now the valve's working perfectly. So that's the valve sitting there in the aorta. And you can see the coronary arteries we injected dye. That's the left coronary artery. That's the right coronary artery. This is a, and so that shows that there's no way the coronary arteries are going to be obstructed there. So this is just playing through once again. So this is the level of the aortic valve. This is the aorta here. And this is just deploying the valve. So this is, so just still pictures here. So this is the aorta, the coronary arteries. This is the catheters come up around the, thoracic aorta, come around the arch. That's not showing the picture. And this is the catheters deploying the valve. This is another catheter coming from the other side just to inject some dye through the pigtail catheter. This showing the 3 leaflets of the aorta. So we're trying to position the valve just there. This showing the valve being deployed by the balloon. Now the balloon's been taken away and the valve's in position. So post-procedure, so the patient was awake. We can talk to the patient while we're doing that. They go to the coronary care unit for 4 hours just to basically to be monitored. It's probably an overkill now. The valve's working normally. We check on echo. It's working, normally straight away. And over 80% of our patients now go home the next day. And I've just seen her recently at a month's follow-up, and she was, feeling great, much better. So TAVI offers many benefits to patients with aortic stenosis. It provides both short and long-term relief of symptoms, as well as improvement in quality of life and life expectancy. And the principal benefits of the sort of less invasive procedure compared to open heart surgery is it's a much shorter procedure. If things go smoothly, which they normally do now, it takes us about 40 minutes from putting the needle in to closing the hole at the end. Much less pain. The only discomfort in this procedure is a bit of local anesthetic at the top of the leg when we put in the sheath. Much shorter hospital stay and a shortened recovery time compared to surgical aortic valve replacement. And there's been multiple studies done, and this is just showing some data showing that as well as the clinical improvements in terms of longevity and things, TAVI significantly improves in quality of life. Things such as just compared to surgery, this is in the first month. All these things go down, usual activities, working, self-care, showering, all these important things, they go down with cardiac surgery, but significantly improve straight away within the first 30 days with TAVI. So TAVI has been introduced in a very robust fashion. There's very good randomized controlled data of thousands of patients supporting the use of TAVI. And it's actually provided very good data for surgical valve replacement that they never had either. So this is just some data. So TAVI was initially introduced in patients that were too high risk for surgery and then high risk. And it was proven that TAVI was very effective in that category. But most patients are intermediate or low risk. And this is a trial that almost 1,000 patients that compared TAVI to surgery in patients that were intermediate risk for cardiac surgery, which means they had about a 4 to 5 to 6% chance of dying through having an open heart operation and aortic valve replacement. And with TAVI, it was shown that the mortality for these patients was 1% at 30 days, 1.1%, and having a stroke was 1%. So these are obviously the 2 dreaded complications, 1 dying and 2 having a stroke. And this was 75% lower than surgery. So at 30 days, the surgeons actually did pretty well too there. So these patients were predicted to have a sort of 4 to 7% chance of dying. So that, with surgery, they had a 4% chance of being dead at 30 days, but with TAVI it was 1.1%. And likewise with stroke, it was 4.4% for surgery and 1 for TAVI. So 75% reduction. And some of these, this has been achieved because there's been a significant improvement in technology. I've already sort of mentioned this a little bit. So we're on the 3rd iteration of the valve that we use. It started with the SAPIEN valve, the SAPIEN XT, then the SAPIEN 3. And as the technology has improved, the delivery system that we take the valve on, we go around the arch and cross the valve with, that's got a lot better, a lot easier to use. We can flex it around, we can stay off the aortic wall. That means because if you scrape along the aortic wall, that increases the risk of stroke. This was the size of the catheter we first used to have to use to introduce a sheath of 22 French that we had to put through the femoral artery. It's almost the size of your thumb. And now it's down smaller than your small finger with a 14 French. That's the size we now. So it's a way smaller than that. And then the valve, initially it was a very stiff valve made out of stainless steel, only 2 sizes, and now it's progressed. It didn't have a skirt on it. Now it's progressed with a skirt made out of cobalt chromium. So that means it can be crimped down to a lot smaller size. And there's also 4 sizes of valve now, which covers almost all people. And this is very recent data showing that TAVI is very effective also in low risk patients. So this is in this trial, they randomized 1,000 patients to TAVI versus surgery in low risk patients, and the average age in this trial was 73. So these are patients who are relatively young in the aortic stenosis population, and who are probably good candidates for surgery, but still TAVI won out in terms of death, stroke, and rehospitalization. There was a significant benefit in TAVI. So over the years, we've been doing TAVI now for almost 10 years, and there's been significant improvements. When we first started doing it, and this generally refers to the whole of New Zealand, we used to have cardiac surgery, a whole team on standby, but basically the cardiac surgical team was scrubbed so they could crack the chest if something went wrong. So we had a bypass machine in the room, we had a cardiac surgeon and all the nurses, and we used to do them all under general anesthetic, and now we do them all under local anesthetic with a little bit of sedation. We used to do them all under transesophageal echo, and we don't do that at all now. CT has been revolutionary. It's been very helpful in planning the procedure. And as I said, we've gone down from 24 or 22 French holes in the groin down to 14 French, which makes it a lot safer in terms of much less bleeding complications. We used to put central lines in all patients. We don't do that anymore. We used to do a balloon valvuloplasty at the start of the procedure to open up the valve, but because the catheters and the valves have got a lot smaller, we don't have to do that so much anymore. We don't put in urinary catheters that come with their own complications. Patients used to go to ICU, and they used to go to recovery and then ICU. They don't do that anymore. They go to coronary care and then the ward, and the vast majority go home the next day. So just a few key messages on this talk. So aortic stenosis is very common. We need to be aware of it. It's very treatable. So 1 in 8 people over 75 years are affected by aortic stenosis. And timely intervention is very important. Without treatment, up to half of symptomatic patients will die within an average of 2 years. That's with severe symptomatic AS. So it's very important to listen for a heart murmur, suspect a systolic murmur as an indication for the aortic stenosis, and refer for an echo or to see a cardiologist for further examination. So just a few final points about TAVI. So TAVI is a viable, less invasive alternative to open heart surgery in patients with severe AS. And it's now proven, it was initially proven in non-operative, it's now proven in high risk, intermediate risk, and low risk patients with aortic stenosis. And it's pretty much now become the default treatment. So most patients with severe aortic stenosis, and this has happened over the last few years, we will have a TAVI, and they'll only have surgery if they need surgery for other reasons, such as coronary artery bypass grafting, or if TAVI is not feasible for anatomical reasons. And this last slide just highlights a new website called newheartvalve.co.nz. I think all the everyone's getting some information about that, and this is patient-directed information about aortic stenosis and the treatment options, including TAVI. All right, thank you.
All right, then that was absolutely fantastic. You can hear your passion when you got into talking about your TAVIs, James. You're like little Christmas tree lighting up.
Oh, yeah.
Right, so we've got some questions to start with here. So the first one we've got here is, can a patient pay for an echo, then return to the public system? In addition no, I'll let you answer that bit first, actually.
No, definitely. I think anywhere in New Zealand they could do that. I mean, echoes are relatively expensive, but yeah, there's no reason why patients can't have an echo and then the GP can refer them in with the result.
And with relation to that, how much is an echo, and is there a waiting list in private?
An echo will vary throughout the country from probably between, I don't know, $300 to $500. And so, yeah, I mean, the waiting list in private would be, 2 to 3 weeks compared to about 6 months and currently in some places.
6 months to a year up here. Yeah, big difference. Now, someone has said here, so you stated that with regards to the BMP relationship to the left ventricular heart failure, but someone's asked about how does it relate to the right ventricular heart failure?
Well, yeah, BMP can be related and can be elevated in that situation as well, but the right ventricle is normally protected in aortic stenosis. It's only fails very, very late. So, and in terms of aortic stenosis, it's relevant in terms of the left ventricle because aortic stenosis puts strain on the left ventricle. But BMP, yeah, it's mainly associated with left ventricular dysfunction.
And then we've got any tips to getting an echo more urgently? What can be written on the referral?
Well, that's why I mentioned there. So if a patient has a systolic murmur and they are symptomatic, if they have exertional shortness of breath, decreased exercise tolerance, if they have pre-syncope or syncope, if they have chest pains, and then I think it's urgent, and you can put urgent on the referral. Suspect severe AS. If patient has a systolic murmur and they don't have any symptoms, then you do your best to coax them out of them. And because, as we said earlier, so many patients think they don't have symptoms, they're just getting older. But getting older is no excuse. It's usually for some reason that they have symptoms.
Okay, so this next one is, how do you define near normal coronary arteries?
Oh, well, I mean, when you're 80, it's very unusual to have completely normal. So near normal is just very mild plaque. You can see some mild irregularities. Certainly would never need to do anything about it. Yeah, but it's very unusual to have completely normal at the age of 80.
Thank you. And so then who gets the TAVI and who gets surgery? I think you've kind of answered this, but I'll just let you.
Well, 2 years ago, any patient, so if you're 75, you've got severe aortic stenosis and you're otherwise well, you would have had to go for surgery. And in some centres around New Zealand, you still have to do that. But we now know there's very good evidence, randomised controlled data, that supports TAVI over surgery in all patient subgroups. So you need to make a good argument for justifying making someone have surgery when they could have TAVI when the outcomes are better. We've seen that, the data is better, they do better, they less mortality risk, less stroke risk. And so there need to be a good argument for them to have open heart surgery. I mean, some of that does come along with funding, because at the moment, unfortunately, with lots of different things, we're probably underfunded for the number of TAVIs that we need to do.
Okay, and if patients develop angina during the procedure when placing the prosthetic valves, do you have to abort the procedure?
No, we wouldn't abort the procedure, but occasionally we do have to protect the coronary arteries. If the coronary arteries are quite low, we can place a wire in the coronary arteries and we can place a stent there, but not deploy the stent. But if the coronary arteries get compromised, we can stent it. We haven't had to do that, but we have put stents in the coronary arteries just in case. But no, we haven't come across patients getting angina during the procedure.
Thank you. And then I've got a couple of questions here about anticoagulation, antiplatelet drugs after placement of these for the TAVIs.
Yeah, so they just go on a single antiplatelet agent, just normally aspirin. Occasionally patients have had strokes in the past and their urologist has them on long-term clopidogrel, and if they're on clopidogrel, we just leave them on one agent. So they don't need, they're a tissue valve, so they're like surgical tissue valves. They don't have to be anticoagulated, so just either aspirin or clopidogrel. But if they have atrial fibrillation, which obviously a lot of these elderly patients do have atrial fibrillation, and they've got another reason to anticoagulate, so we're happy for them to be on an anticoagulant agent and not a antiplatelet.
Right.
Usually not both.
So to the best of your knowledge, where in New Zealand can patients get TAVIs at the moment?
Well, I know exactly where. They can get them in Auckland, Hamilton, Wellington, Christchurch and Dunedin. And, you know, both at the public hospital and privately in those centres.
Lovely. And what would you say is the average age of the patients going through?
Well, when we first started doing this, our average age was about 84. And now I'd say if we just counted our last couple of years, our average age is probably about 79. And yeah, that's probably our average. It'll be coming down because we started just doing the very high risk patients who are very high risk for surgery. But with time, as the evidence has got better for the intermediate risk and the low risk patients, we are now doing all risk categories. So the age is coming down.
It's very exciting stuff, eh? Because you'll be able to ping through a lot more than you would do with an open heart.
Well, we can do
surgery.
We usually do 3 TAVIs by 1:30, 2 o'clock a day, and
fantastic.
We could do more if we were allowed to.
Is AF a contraindication to TAVI?
Or is that AF?
AF.
AF. No, not at all. A lot of the patients have AF, and that's just another comorbidity that we take into account. And no patients can have a TAVI for sure.
And what sort of cost? We all like to know the money value. What sort of cost would you be looking for a TAVI in private?
Well, one would hope they have medical insurance or other, because unfortunately the TAVI valves are very expensive because you know, there's been huge costs involved in bringing these to market and doing the big studies and things, but you don't really get much change out of $30,000 for a valve, just the valve. And then there's a whole team that goes with that and the cath lab time. So it can get up towards $60,000 for the procedure.
Wow, for one day in hospital, eh? 60, woohoo, exciting. Now we've got one here and I'm not quite, so someone's asking, do Maori and Pacifica get atrial, I suppose that's what they're saying is, do Maori and Pacifica get aortic stenosis needing correction? So I guess they're talking about that, yeah.
Yeah, I think they probably get it just as commonly. Yeah, they definitely get aortic stenosis. Yep.
What sort of ratio would you say between Maori and non-Maori? Are they similar, or is there a?
Well, I think it probably reflects the population. Obviously, in Christchurch, we don't have as high a Maori and Pacifica population as in Auckland, for example. And I'm sure I don't know what the Auckland figures are, but I would say it should reflect, you know, what the population proportions are. They certainly don't get it more commonly, but there's no reason to think they don't get it.
What time frame after TAVI is recommended before undergoing elective non-cardiac surgery, e.g. a hip or knee replacement?
Yeah, well, we have had patients undergo urgent surgery within 36 hours of doing a TAVI. That's when they needed urgent abdominal surgery. But, you know, I mean, I wouldn't mind if someone had a hip replacement within 2 weeks of having a TAVI.
Okay, and then we've got a couple of questions around a similar angle here, looking around what would be the contraindications for going ahead with a TAVI, which haven't. Well,
okay, so occasionally we mainly do, well, almost always do TAVI by going in through the femoral artery at the groin. And occasionally if someone has severe peripheral vascular disease, we can't do that. So you can't get the catheters in through the, because they've got severe narrowings of the femoral or the iliac arteries. And if that was the case, there are other alternative ways that you can go, and you can go through the subclavian artery at the top of the arm. You can go directly through the ventricle and put a valve in that way. Or there's something called a transcaval when you go into the inferior vena cava and through the vein and then go through the vein into the aorta. So there are several ways of getting over that, but that's a potential patient who can't have a TAVI, severe peripheral vascular disease. And then there's some patients have anatomy of the aortic valve that's very, very heavily calcified, or if the coronary arteries are very low, then it may be better for them to have a surgical valve if they're suitable, because you don't want to obstruct the coronary arteries by the valve.
And then how do GPs look after TAVI patients post-op?
Well, hopefully the patients will be feeling a lot better straight away, and they'll be easier to look after them than what they were prior to the TAVI, prior to having their valve done. And so people are often on diuretics, patients are often on diuretics leading up to with severe aortic stenosis, because it does help with the symptoms. And I think it's important often to keep the diuretics going, because with aortic stenosis, the ventricle does become quite stiff, and and they have diastolic dysfunction, so they still need some diuretic. So it's important not just think, oh, we've put a new valve in, we'll stop all their medications. But I would hope that the patients are better, they're easier to look after, and there's no really thing special you need to do for the TAVI valve.
Lovely. And how long after a TAVI can they start driving again?
Well, I think it's 2 weeks, because I think it's 2 weeks, but I don't quite know why it's 2 weeks. It doesn't need to be that long. It could be as soon as because the valve, we do an echo straight away, and once the valve's working perfect, once the valve's in, it's working, it's fine, and then the valve's in, it's fine. So that's relieved their aortic stenosis. Then it's just letting the groin site heal. We make quite a big hole in the femoral artery, so you want to make sure you go easy on that for a couple of days. I think the LTSA guidelines still say 2 weeks, as they regard it as an aortic valve replacement.
And along the similar lines, but a little bit more exertion here, and about how long after TAVI can they have sex?
Wow, I haven't been asked that question before, but I don't know, probably I'd say 48 to 72 hours if a patient asks me. Just as long as it doesn't bleed from the groin.
That's an active sex life there, I think.
I'll be
and then we've got, during the insertion of the valve where the blood flow is blocked for 10 seconds, are there common adverse outcomes?
No. So the blood flow is not blocked. So basically it just puts the heart into cardiac standstill. So the cardiac output just stops for 10 seconds. And it's incredible that patients, they're awake and they don't even know. They don't even read. Occasionally, if we go for longer, they might feel a little bit lightheaded, but no, the patients tolerate it remarkably well.
And we've got here is an indication. Oh, so is there an indication for surgery, so open heart surgery, if the TAVI fails in the first attempt?
Yep, that was one of the concerns about TAVI, is that if something goes wrong, then generally speaking, there are complications like rupturing the aortic root, the valve. If you put too big a valve in, that's certainly a potential. But generally speaking, if you have a devastating complication of TAVI, it's probably not going to be feasible to mobilize a cardiac theatre and open the chest. These patients are generally elderly, they wouldn't survive that. So it's very rare, and it's more common to have patients coming to the cath lab for emergencies from cardiac surgery than the other way around now. It's a bit of a myth that you need backup cardiac surgery for any procedures in the cath lab.
All right, so you did answer this anyway, but I'll let you just give them another answer. So they just said about the risk of death, stroke during after procedure. That was quite early on in your presentation.
Yeah. So the risk of those serious complications, it depends on the comorbidities of the patient and what their overall risk profile is, start of the procedure. So if you've got a low risk, we're doing 3 patients tomorrow that are all relatively low risk, and I would quote their risk of death as being 1% and their risk of stroke as being 1%. Their risk of having a major bleed from the groin as being very low, well less than that. And we haven't talked about pacemakers. Occasionally, if people have got a pre-existing bundle branch block, that increases their risk of pacemaker requirement. Occasionally, people need a pacemaker afterwards, and that's the same with open heart surgery. So it depends on, if a patient's 88 and they've got an ejection fraction of 20% and they had a previous stroke and they've got coronary disease, then their risk of the procedure increases.
Thank you very much. That's fantastic. Now, just so everyone knows, as I believe there is a discussion form is coming out with the webinar at the end that James has put forward, giving a guide to talking with your doctor, that will be circulated as well, which has got some information about symptoms to look for, questions to take to appointments, just to give people a bit more thought around that. But yep, no, I think you've done it, James. Thank you. No more questions falling in. Just the thanks are starting to arrive. Somebody saying about a good job and very informative. Great presentation. I personally loved it. Thank you very much.
All right. Thank you.
Thank
See
you.
you. See you.